a clinical perspective to what we are talking about. So, first of all, when you want to talk about joints, one of the things you have to do is to let us understand what kind of joint is this. And there are basic things that cause for the identification of the joint, not just the location in the body. You must tell us the kind of joint that we are investigating, and also you tell us what constitutes the joint. What are the particular structures that highlight that joint and makes it different from other joints? And so for the hip joint, as we all know, it is a ball and socket joint. That's quite common knowledge. And it's also a synovial joint, meaning that it's lined by a synovial membrane. And the articulating surfaces, when you hear articulating, it's not a big word. It just means the surfaces that are joining together, that are fusing together to form that joint. And so the surfaces that are joining together are, first of all, we have the acetabulum of the pelvic bone, and then we have the head of the femur. So these two structures are the structures that join together to form the hip joint. And this hip joint is what connects the lower limb to the pelvic girdle. You know, the pelvic bone, the pelvic girdle, that is constitutes of the ischium, the pubis, the ilium, and it's mainly for weight bearing. So let's further investigate this articulating surface. Right in the acetabulum of that pelvis, the acetabulum is a cup-shaped depression. When I will show us the structures later on, but I want us to try to visualize something that is cup-shaped. It means that it's shaped like a cup. It has a hollow structure. It's hollow, and then it's firmly suits the head of the femur, which is hemispherical. So the articulating surfaces are this acetabulum of the pelvis, and then the head of the femur, which is hemispherical. But then there is something in that acetabulum that increases the stability of each joint, and that's the acetabular lap. And what it does is it's a fibrocartilage, and what it does is that it deepens that acetabulum so that the head of the femur can fit can fit in properly into that hollow surface and stabilize the joint. I can't wait for us to get to the pictorial parts, because you cannot study anatomy without investigating the structures and seeing what you are studying, especially gross. Okay, so of course we know about the joint capsule. It's a fibrous joint capsule lined by the synovial membrane. And you know that within the synovial membrane, we have the synovial fluid that helps to lubricate, because the joints are consistently moving, especially the movable joints. And so the synovial fluid helps to lubricate those surfaces that are articulating, so that there will be less friction, and so that movement can be seamless. Okay, so we're going to be looking at the structures that warrant the stability of the joints. The structures that make up the joint and cause it to be stable. And we're going to be looking at it from these dimensions. We're going to be seeing the bones, the ligaments, the muscles, the bursa, and the joint capsule. Are we together so far? Are we together so far? Are there any questions so far on what I've said? I think those are just the introductory parts. I'll be looking at the chat box to see if there are any questions. Are there any questions so far on what I've said? Any questions? So I can move ahead. I would have even loved it if people can unmute themselves and just say one or two things, so that I'm sure that you're following what I'm saying. Okay, let me pick someone at random. Mesoma Achu. Sorry that I'm picking you at random. If you can hear what I'm saying, can you unmute yourself and affirm to the fact that you can hear me and you're following them so far? Mesoma.
Sorry, I didn't get what you said.
Mesoma there.
Yes, I can hear you, but
Okay,
I
who is
didn't
there?
get.
Who is there at all? I hope we are following what we do. Or is it because it's online and you left the class to go and cook?
No, sir. Can you hear me, sir?
Yeah, I can hear you. Okay, I can hear you now.
Yes, I can hear you, sir, but I didn't get what you said. What you asked me, I didn't get it.
You didn't get what I said?
Yes,
No,
like what you asked me to
I
do.
wanted to know if you're following so far, if you're following what I'm saying so far. Do you have any questions so far on what I've said?
Okay, no, sir. I'm following. I understand what you're saying.
Okay, you understand so far. Let's look for a man. Is there any man in this class? I can't even see a man here. Is Alan a man? Alan, Alan. Is he a man, a woman? Are you following us so far? Can you unmute yourself and let me be sure that you're following us so far. You see? Okay, so let me not waste our time. We have boys. Okay, we have boys, no men. All right, sir. Let me not waste so much time. But please, if at any point you cannot hear what I'm saying, please, I would like you to call my attention so I can repeat myself. Because I reckon that the network is fluctuating and sometimes my voice will break. Okay, so let's look at what causes for the stability of the joints, the hip joints. We first of all look at the bones. We all know that the bones involved are the femur and the pelvis, basically, But then the pelvis, we have three bones that can be investigated in the pelvis, and these bones are joined together by immovable joints. So they are kind of stable and they allow for just slight gliding movements, very insignificant movements. Okay, but they are quite significant in our female due to the fact that they are involved childbirth. So, and then the ligaments that we have are the intracapsular and extracapsular ligaments. There's just one intracapsular. Intra meaning that it is within the joint capsule, and then extracapsular means it is outside the joint capsule. And so the one that is within the joint capsule is ligamentum teres. This is just the ligament to the head. This is the ligament to the head of the femur. So it's a very common ligament, and it calls for a very slightly significant stability for the hip joints. But for the extracapsular, we have iliofemoral, pubofemoral, and ischiofemoral. Now, if you look at the bones that constitute the pelvis, you will see that all the bones are being, stabilized together by a connection of ligaments that connects them to the femur for the ilium, ischium, and pubis. So how they form the names of those ligaments is that they just put the name of the bone and then the name of course, the femur that they are connecting to. So iliofemoral simply means the ligament that is connecting the ilium to the femur and so on and so forth. Okay, so let's appreciate the pictorial view of the hip joints. So right here, we can see, I wish I had, where's my pointer? I think there's the pointer here. Okay. So look at this. We have the ilium here. This is the ilium. Remember that all these bones, the whole bones here are the pelvis. Okay. So we have the ilium, we have the pubis here, and then we have the ischium here, right? So these three bones that I've just circled now are what they are responsible for, formation of the whole the pelvis bone. And we can see the femur here, the almighty organ femur, and we can see the head of the femur. So if you notice, I told you that the hemispherical head of the femur, this hemispherical head, connects with the cup-like depression here. This cup-like depression here is the acetabulum of the pelvis, and then the head of the femur. So, and this is of course, the neck of the femur, which we have fractures that occur here sometimes if there is a massive trauma to that place. And so now that we have seen what we can appreciate as the bones and all that, let us now move further and see other aspects of what causes for the stability of that joint. Okay, So let's move to the next slide. Sorry, let me switch this off. Let me clear my documents. Okay. All right, so moving to the next slide, we'll look at the ligaments. I told you that there are two classifications of the ligaments. We have the intracapsular and extracapsular. So you can see that the ligaments here, we can see, first of all, let me bring my pointer again so that you can be seeing what I'm saying. So we can see, first of all, these two here are the iliofemoral ligaments. This one here and this one here. Let's talk about the iliofemoral. So this is a wide shape. You can see the wide shape of this iliofemoral ligament, and it is connecting this ilium together with the femur. I'm sure we can see this very clearly. It's very clear there, and it's Y shaped. So this is the strongest ligaments that we can find in the hip joint, and then it helps to prevent the hyperextension of the hip. So you cannot. It helps you it helps you to form is a form of regulator to regulate the rate at which we extend the knee, so that it doesn't go beyond the range of extension that is required. If not, there will be, if you try to overextend that knee, what you're going to cause is a tear of this ligament, and then you will have serious complications at that moment. So we've seen iliofemoral, we said is Y-shaped, that's number one, and then it is the strongest. The next one we'll see is pubofemoral. So here is the pubis, right? And then this is the femur. So we can see the pubofemoral as it's labeled here, pubofemoral. And this one is triangular shaped. So look at the shape here. Sorry, let me redo that. Look at the shape of this one. So it goes this way, goes this way, and goes this way. That makes up for the triangular shape of the pubofemoral. Remember, we said this one is Y-shaped. Pubofemoral is triangular shaped, and it's also the second strongest of it. It prevents excessive extension as well, and also adduction. And then the final one is the ischiofemoral. So we cannot see the ischiofemoral when we are looking at this anterior view. That's why I put it here. This is the ischiofemoral. So this is a posterior view of the hip joint, and we can see the ischiofemoral connecting the ischium and of course the femur. And this one, it doesn't have, it's spiral shaped. It just moves itself around, the head and the greater truncata there. You can see the greater truncata and the lesser truncata of the femur. So it just weaves itself around it, and it helps to prevent excessive adduction this time, not abduction, adduction this time around. So we've seen the ligaments. What you will need to do now is to go and do an in-depth study of the ligaments and find out the specific structures that they affix themselves to. So let's take, for instance, this ilium now. So this is the inferior iliac spine. You can see this, the iliac spine here, this spine. This is the inferior iliac spine. So it connects from the inferior iliac spine, and then it bifurcates, inserting into this place is the greater truncata, lesser truncata. So this place now is called the intratruncateric. I'm speaking so many English now, but this is the intertruncateric line. So you can see from the inferior spine, iliac spine, and in between is there right there between the two truncatas, that's intertruncateric line. So what you need to do at anatomist now is to go and find out the specific structures in the pelvic girdle that these ligaments affix themselves to, and you can move on from there. So let's go on. We've spent so much time here. Then the muscles and the movements that are involved in the muscles. This is somewhere that we need to also pay attention, and we have our diagrams. So for the flexors and the adductors, Let me put my pointer again so that you can be seeing what I'm saying. For the flexors and the abductors, is my pointer in? Okay, so flexors and abductors, we can always, no, sorry, not abductors, and adductors, double D. So we can always appreciate the muscles that bring about flexion and adduction in the anterior aspect. So we have the iliopsoas muscle, which is comprised of the psoas major and the iliacus. And then we have the rectus femoris muscle. And then for the adductors, we have adductor longus right here, adductor brevis, and adductor magnus. Then we have the gracilis muscle there. Okay, so moving ahead from that, let me select my mouse. Let's forge ahead. Then for the extensors, we can see them from the posterior view. So we have the gluteus maximus, gluteus medius, and the piriformis muscle here, and then quadratus femoris muscle. So just know that the flexors and adductors, ADD, double D, are found in the anterior compartment, while the extensors and the ABD, the abductors, found in the posterior compartment. And then we have the rotators, which are the piriformis and rotator internus muscles. Okay, so go and study further and internalize those muscles. Shouldn't dwell on them so much because we are studying the joints and not the muscles for now. So for the bursa around the hip joint, well, we have two main bursas. I pointed out two main bursas here. Other ones are relative, but then you can also study them for knowledge purposes. But for the hip joint, we have the greater trochanteric bursa. What's a bursa? Can someone help me and define a bursa? Let's see if we've been reading ahead. Someone in the comment section, or someone can unmute themselves. Someone that is hearing me. What's a bursa? When you hear the word bursa, what's it all about in a joint or wherever you heard it? I'll point at people if no one is saying anything. I would like to point at somebody. I'm seeing Amara Mira. I'm seeing Chidozie Calvina. I'm seeing one for favor. Someone should build a cat. What's a buzzer? Anybody? Anybody? Obi John Bosco. That's a very interesting name. What is a buzzer? What's a buzzer? Okay, Favor, you want to say something?
Yes, a bursa is a fluid-filled sac which can reduce friction between joints.
Okay, thank you for that attempt. A fluid-filled sac. Okay, can someone else tell me what fluid fills this sac now? This sac here, according to what we've said, I've said something about a fluid before. So, which fluid in particular fills this sac to perform the function of a buzzer? Someone else, apart from Favor. I think Favor has said something. Someone else? Who said something? Please, before you say something, I would like you to introduce yourself so I will know those that.
Okay, my name is Christabel.
Okay, Christabel.
Synovial fluid.
The synovial fluid. Okay, thank you very much. That is actually correct. And I think it's very important that we know that the buzzards are there to create a form of space and act as shock absorbers, because the joints are consistent, and we can't say that friction will not occur if there's consistency. So that's why the buzzers are littered all around. So we have the greater trochanteric buzzer, which we can see in this. You can see the trochanter buzzer here, and then iliopsoas buzzer, which is also somewhere here. I don't know if I should mark it or are we seeing it? So look at the one I'm talking about. This one here, and also this one here. So these are the two buzzers that are very much relative to the joint. While the ischial tuberosity buzzer, you might include it as part of the buzzer that is relative to the hip joint, but I do not usually include that. And then we also have one here, the gluteus medius buzzer. I also do not include that. But since it's here, it's advisable that you include it because it has been indicated in the class. Okay, so let's move ahead. After buzzer, the next thing we have is the neurovascular supply. So for the neurovascular supply, we have artery, veins, and innervation. That's neurovascular. Vascular is arteries and veins. Neuro now involves the nerves. Okay. So for the arteries, we have the medial and lateral circumflex femoral artery. Please pardon this S here. It is not supposed to be an S. It is supposed to be an X. So that was an error. Please pardon it. And so back to what I was saying. So we have the medial and then we have the lateral circumflex. So look at this LCFA that is here. LCFA. It's just talking about lateral circumflex femoral artery. And then we have this one, which is the medial. So the lateral is just here, while the medial is here. As simple as that. And this is an anastomosis. Who can tell me what an anastomosis is? Our anatomy students. When you hear anastomosis, what comes to mind? Mind me, I like asking so many questions just to make sure that we are following. Someone that has not spoken before should speak. I have Chidozie. I've not seen any guys speaking here. Are you sure guys are in this class? Or am I John Bosco? Okay, you say you're a guy. And tell me something, John Bosco. What's an
Okay.
anastomosis?
Good afternoon, sir.
Yeah, good afternoon, John Bosco. I like your name.
Okay. Anastomosis is a surgical connection or joint of two structures.
The surgical connection or what?
Joining of two structures.
Of two structures. That looks like something that you just press now online. Yeah, fast typing. But I commend that effort. And yes, it can be created surgically. But this anastomosis here now, when you think about it, was this one created surgically now? This one, this medial and lateral circumflex. Okay, was it created surgically? So sometimes before we, actually make some comments, I think we should ruminate on it first. Because if you say it was surgically done, it means that these circumflex arteries here were surgically produced. Okay, but what do you think now? Can you say that this one was surgically produced? John Bosco,
No,
don't
sir.
bail
No,
on me
sir.
now, John Bosco.
No, sir.
Okay, so you see, so is there any other definition you think might suit what an anastomosis is now in this aspect now? Just look at these structures. What comes to mind? If I say that this is an anastomosis, what comes to mind? What can you say? Anybody can help out
Okay.
actually.
The bones,
But John Bosco,
the
I'm
bones are
referring
joined.
to you.
The bones are fused together. They're joined together, like they cross each other.
Yeah, the bones. No, focus on the arteries. These things, these red things you are seeing now are arteries, and that's what I'm saying. Anybody can help. Paradise. Who is Paradise? I like that name. Someone should help. What's an anastomosis from what you're seeing?
Anastomosis can
Anybody
be
at
an
all?
interconnection of blood vessels.
Okay, interconnection of blood vessels. That's a very good attempt. Thank you, Favor. So both blood vessels, any hollow tubular structure, that interconnects to such a degree can form an anastomosis. It can be blood vessels, it can be nerves. So far as they are hollow tubes, they got anything at all, that can be called an anastomosis. Okay, so for the venous drainage, thank you very much everyone for your attempts. I like the fact that you are following the class. So for the venous drainage, we have the internal iliac vein and the external iliac. That's simple to know. And then for the innervation, so let's see the innervation. We shouldn't dwell so much here. So let's see the innervation. We have the femoral nerve, We can see this one here. This is the femoral nerve. We can see the obturator nerve. You can see the sciatic nerve. That one runs posteriorly. That's why you cannot see the full thing. It runs posteriorly from this way all the way down there. And then superior gluteal is somewhere around here, but it is behind because of, the gluteus. Remember, the gluteus muscles are behind. So we will not be able to see it from the anterior perspective. So all these nerves make for the innervation of the hip joint. Okay, so seeing the structures there, it is quite simple to, remember that at this point. Okay, so let's move over to the clinical correlations. And then before we move over to the next one. So some clinicals. The first one we have is the dislocation of the joint. So the dislocation could either be acquired or congenital. Congenital meaning that it happened during development. Okay, if you're conversant with your embryology, you'll be hearing things like congenital malformations, congenital this, congenital that. It's just trying to say that that can happen during the developmental stages of that individual. So we have congenital dislocation, and this happens as a result of DBH, developmental dysplasia of the hip. This happens when the acetabulum, remember the acetabulum that I showed you, the hollow structure that the head of the femur inserts to. It happens when that acetabulum is shallow, and it's shallow because there is a failure for it to properly develop and get sunken during development. And so what happens is that you will notice that there is a limb length discrepancy. So the affected limb looks shorter. Then there's like an asymmetrical, that means it's not symmetrical. When you hear asymmetrical, it means it's not symmetrical. The gluteal folds are not symmetrical. So you can see one part of the nyash going up on the other part going down, just for you to understand. So how is this treated? So it can be treated in two ways. The most profound way is using the pelvic harness, and it's like a sprint. The pelvic harness is like a sprint. It holds the head of the femur together with the acetabular fossa so that it can help for the normal development of that hip joint. Or if in a situation whereby that sprint does not work, that's the pelvic harness. You can now try surgery. Okay. Then the next one is acquired dislocation, and this happens as a result of trauma. That's the most common cause of dislocation. Please, someone should not be using the draw. I'm the only one that should be using the BCO. So as a result of trauma, and it's during this acquired dislocation, it can either happen anteriorly or posteriorly. Remember what dislocation? Dislocation is not fracture. Fracture is that the bone broke. Dislocation is that the bone left its normal placement. Okay, so the head of that femur can either dislodge from that acetabular fossa, can dislodge either anteriorly or posteriorly. But if you remember when we were looking at the ligaments, we saw the humongous number of ligaments in the anterior dislocation. It's not like it cannot happen, but anterior dislocation is very rare. But posterior dislocation is the one that is very, very common. And when I was telling you, it was just the ischiofemoral ligament that we saw the posterior perspective of that of the hip joint. So it's very common. Posterior dislocation is very common. And also the affected limb is shortened as well. There's discrepancy. Okay, so what's the treatment? We do a closed reduction, just like also it's the same procedure with the public that sprint I talked about, pelvic harness, or you can also do an open surgical procedure to correct this dislocation and put it back into where it's supposed to be. Okay, and then other ones include osteoarthritis. I don't want to spend so much time on this, okay? So I'm just going to walk through it. And this is just as a result of wear and tear. That's what happens. It happens very common in elderly people. You notice pain, stiffness, and difficulty in walking. So some NSAIDs and sometimes surgery can also be done to correct it. Tendinitis, whenever you see things like itis, all these itis, it's most likely talking about an inflammation. Okay. So when you see itis like this, itis in the ending side, It's mostly talking about an inflammation. Appendicitis and the rest is just inflammation. Okay, and so those are some of the symptoms: pain, tenderness, swelling, and also some of the treatments that we can adopt, to to correct such situations. And then finally, okay, I think that's where we'll end for the hip joint. I think at this point, I'd like us to ask a few questions before I quickly run through the knee joint. I would like questions at this point in time. Just in the next few minutes, let's ask questions. Or I will ask my own, just to be sure that we are following. Either you ask or I ask. Which one are we choosing? Are you the ones asking or am I the one asking? Some new people joined us, Kosiso, and the rest of them. Welcome. Mbanusi Blossom, Honorable Adeze. Okay. I think maybe just for subsequent times, we will need to name our accounts, use our names so that we can be easily identified. But I'm seeing Idel this, Idel that, Xiaomi, and Samsung as people's names. Okay, questions. Any questions, or do I go ahead?
Sir,
Okay, let me
please, what did
ask.
you say?
Okay, I didn't hear you. Please come again.
What did you say the pubofemoral ligament prevents? Sorry.
Okay. Any other question before I attend to her?
Okay, my question is, I'm not clear with the ligamentum teres, where where it is.
Ligamentum what? Teres.
Teres, yes. It wasn't shown on
Okay.
the pictorial representation.
Yes, I told you that ligamentum teres is the ligament to the head of the femur. You will need to dislodge the femur to be able to see, that's this. But in that diagram, we don't have a dislodged femur. We have a femur that is firmly, set into the acetabulum fossa. That's why you will not be able to see the ligamentum teres.
Okay.
You
Okay, sir.
understand?
Thank you.
Yeah.
Yes, sir, thank you.
Okay, so for Favor, were you the one that asked about the pubofemoral?
Yes, sir.
Okay, so let me go back to that place so that we can be able to see the pubofemoral. So that I think if you see it, then you'll be able to understand what I'm saying. So remember, let me bring my pointer. This is the pubis, and this is the femur. And we say that the pubofemoral is triangular, right? It's something like this. And it is connecting the pubis and the femur, and it's triangular shaped. Now, you are seeing that it is in the anterior compartment. Can you see that it's in the anterior compartment? Favor, are you
Yes,
there?
I can see it. Yes, yes.
Okay. And you can also see that the iliofemoral is also in the anterior compartment. And so, when you want to extend the femur, it is these two structures now that will prevent excessive extension of the femur. You understand? So that the hip joint does not extend beyond what is necessary, right? And I said that if it extends beyond that, there will be what? A tear, right? So what this iliofemoral and the pubofemoral, what they mainly do is to prevent that excessive extension of the hip joint. Okay?
Yes, sir.
Is that clear?
Yes,
I don't know
sir.
if
Thank you.
Okay. Thank you very much. Any other questions? I like when people ask questions. It means they are following. Please, when you are studying your anatomy.
Sir, please. That anastomosis, I did not get it very well.
Okay, thank you very much. Because I was wondering, how did people get it so fast? Any other question? Any other questions that we can put ahead? Anastomosis, someone is saying.
Sir,
Please,
please,
who
I
said
didn't
this
get it.
person did not get anastomosis, please? What's your name?
Chisom.
There might be marks for asking questions.
Sir, my name is Chisom.
Okay, Chisom. Someone wanted to ask another question now.
Sir, please, I didn't get the buzzers. Those buzzers.
Okay, so Chisom did not get anastomosis, and who is saying that she did not get? But is it Idel? What's your name?
Deborah Okafor.
Deborah. Okay, so he didn't get the buzzers. All right, so I'll quickly run through them. Any
Sorry,
other
I have a
question?
question too.
Okay, please identify yourself.
Okay, my name is Peace.
Peace.
Um,
Okay.
yeah, you were saying something about the vein drainage in the hip joints that is from, I think, the iliac. I really didn't get that part because when I read the textbook, they were saying it's from the femoral vein. That's
Yes,
where
of
the
course.
venous drainage.
All right. So, what's your name? Peace, right?
Yes, sir.
All right. Okay. Any other questions? More questions, please. More questions. So I can be sure that I've handled this. Any other questions? So I have questions from Chisom, Deborah, and Peace. And after that, we are satisfied with hip joint. Okay, so let's move. Chisom asked about anastomosis. Let's go to where we saw anastomosis. So look at this structure here now. Can you see, Chisom, can you see? So when it's your turn that if I'm answering your question, just unmute yourself so two of us will be communicating. Okay?
Okay.
Yes. So Chisom, can you see the structure, the arterial supply?
I'm seeing it, sir.
Okay, let me clean these things first. So here's my pointer. Look at this circular structure here around the neck of the femur. Can you see it?
Yes, sir.
Okay, so remember that structures that are closer to the midline of the body are medial, while structures that are farther away from the midline are lateral. Do you understand that? Chisom, follow me now. Where is Chisom?
I'm here, sir. I'm hearing you, sir.
Okay, so what we mean by an anastomosis is that whenever you see hollow structures, whether it is an artery or a vein or whatever it is, hollow in the sense that they are like a tube and they are hollow. Hollow means that there's a hole inside it that helps to, yes. Whenever you see hollow structures joining together at different occasions, within the same vicinity, within the same location, within the same place, that joining together you are seeing can be called an anastomosis. Is that a better explanation? Yes. So
yes,
you can hear something like anastomosis around the knee joint. When we do knee joint, now you see another anastomosis there, and it's just blood vessels joining together within that same vicinity. Is that clear now?
Yes, it's clear.
Okay, thank you very much. And so next person is Deborah. Deborah, unmute yourself. Let's go to buzzers. Where is Deborah?
I'm here, sir.
Okay. Yes, Deborah. Your voice sounds familiar. Don't worry, we'll talk later. Okay, so Deborah, can you see this structure here?
Yes, sir.
Yes. You are these places that are colored like almost like water or like a cartilage. Can you see them?
Yes, sir.
So the idea of a buzzer around a joint is for there to be spaces that are filled with synovial fluid, that lubricating fluid I told you about. Those spaces are so that they will give room for movement of that joint and provide and reduce the friction that is happening in that joint. If there are no buzzers, there will be a lot of collision of structures and the bones are hard structures. There will be a lot of friction, a lot of collision. In fact, the kind of friction that might occur if someone walks for, let's say you walk from Ogovia to Ameleba, or you walk from school to St. Joseph's Lodge, in down that side. The kind of friction that will be produced, if there are no buzzers, it will readily cause inflammation because there is no space that allows for those structures to move freely. That is why the buzzers are here. So buzzers are fluid-filled spaces. They are filled with fluid. And the fluid that we are talking about in this aspect that is synovial fluid. You get? So
Yes, sir.
these spaces help to, number one, they cause for stability, and number two, they reduce friction. You know? So is that okay? So
Yes.
the one that we have here is the one I told you about, the two men about this trochanteric, and then this one. Ellipsoas. Those can be included by other textbooks. These Bluetooth MIDI spots are textbook you're using. All of them are correct. Is that
No, sir.
okay?
Yes, sir.
Hello, Deborah. Is Deborah here? Deborah.
Yes, sir.
Deborah.
Yes, sir. I'm here, sir.
Can you hear me? Am I audible?
I can hear you now.
Okay. Okay, thank you. Are you okay, Deborah?
Yes, yes, sir. Thank you,
Are
sir.
you okay?
Yes, sir.
All
Thank you,
right.
sir.
Okay. Then the last person is Peace. Peace talked about blood and venous drainage. And I said we have internal iliac vein and external iliac vein. Is that not what I said? Peace. Peace, unmute yourself so we can talk.
Yes, sir, that's what you said.
Okay. Now, these two iliac veins, do you know the veins that originate them? Maybe you want
Yeah.
to check. Eh?
I want to check.
Eh?
I want to check it out.
You want to check? I don't think I can hear you, Blue. Hello, can you people hear
Hello?
me?
Yes, I can hear you.
So, do you know what originates the iliac vein?
No, sir.
What's happening to my network? Hello, please, if you can hear me, can you just say something in the chat box?
So I can hear you.
Yes, can you hear me now?
Yes, yes, I can.
Okay, I was asking you, this internal and external iliac vein, do you know the vein that originates them?
Yes, sir.
Uh,
Yes, sir, I do.
which vein is that?
The femoral vein.
Yes, the femoral vein. So these two are more specific. Do you get? It is the femoral vein that
Yes.
gives off these two branches, and they are more specific. If you say femoral vein, you can still pass. So you get, but it's not
Yes.
specific. All right. So thank you very much. In the absence of any other questions, I think we should move over to uh, knee joint. And for this one, I'm going to speed up a little because of my time. I think we have just how many more minutes? Supposed to end this by, this is 1:39, so we're supposed to end it by 2. Okay, so the same thing for the knee joints, introduction, joint capsule, and the rest. Knee joints, this one, remember that we said that the hip joint is ball and socket, but this knee joint is hinge. Hinge, meaning that it allows movement in just one direction, okay? Just forward So that's what's hinges for the knee. It just extends and flexes that up. And then you can have medial and lateral rotations in mild forms when the knee is flexed. So you must tell us that it is a hinge type, and you must tell us that it's a synovium. And then you must tell us the structures that are joined together to form that joint. So for the knee joint, we have the patella, the femur, and the tibia. And another name for the patella is what? Anatomists? Another name for the patella, anybody can answer, please. Another name for the patella?
Kneecap.
The kneecap. Thank you very much. So this is a very complex joint, and it's good for you. You employ it when you are walking, running, and jumping, and the rest of them, especially when you are moving. I've talked about the articulating surfaces and the rest of them, so I'll not waste my time on this place. Tibiofemoral. Okay, let me say something here before some people crucify me. This thing that looks like a big English. Let me break it down. The knee joint consists of tibiofemoral, patellofemoral, and patellofemoral articulations. This simply means tibiofemoral, tibia and femur, patellofemoral, patella and femur. Simple. Doesn't call for any alarm. So the medial and lateral condyle of the femur, I will still show you that, will now articulate with the tibial condyles. While for the patella, the anterior aspect of the distal part of the femur will now articulate with the patella. Let me explain what we mean, because this one is not looking like Google English. Okay, we'll still see these ones. So look at what I'm saying here in this place. Can we see the femur? Everybody, I'm sure we can see the femur here. So we can see that the femur, in this femur, we can see the patella resting in front of the femur. And then we can also appreciate the fact that the condyles, let me highlight the condyles so we can see the condyles, because it's looking as if we're not following. Even myself, to an extent, with what I'm saying, I know you will not be able to follow what I'm saying. So look at what I'm saying in the articulation. This femur is joining to the patella. Though this is the first connection I'm talking about. Then the second connection is this same femur is joining with the tibia. That's the second connection we're talking about. As simple as that. These are the connections that cause for the knee joint. 3, not 2. Okay? And what this patella is doing is that it is helping to protect the anterior aspect of the femur, so that direct hits in this anterior aspect of the femur will not overly affect the knee. Just imagine if you are told to kneel down now and there is no patella in your knee. Do you know how terrible it will be? Or you are walking long distances and there's no cushioning by the patella for your knee, or you're even running. So when you think about it, you can see that this patella here, in God's wisdom, God puts this patella here for a great deal of purposes, both protection and stability and the rest of them. So that's what I'm talking about. So I've talked about the bones already involved, femur, patella, and tibia. The femur and the tibia are long bones. Why this patella is a sesamoid bone? Sesamoid is that sesamoid shape, right? So let's see the ligaments that are involved. Let me go back so that we'll see the ligaments involved. The ligaments involved, the first one, the patellar ligament, I'll still look at it. This thing is not erasing. Let me erase it. Sorry about that. Okay, so let's see. We have the patellar ligament, number 1. Collateral ligaments, there are 2 of them, medial and lateral collateral. And then we have cruciate, anterior and posterior. Let's go to the diagram and appreciate them. Let's go to the diagram and appreciate them. So look at it here. When you hear cruciate, it just means that Those ligaments crossed together. That's all. Cruciate. So we have anterior. The one that crossed anteriorly is anterior cruciate ligament. And the one that crossed posteriorly, look at the two of them here, is posterior cruciate ligament. That one is very simple to understand. Then we have the collateral. We said the collateral, we have medial and lateral collateral. It's not what we said. Medial in the sense that it is in the medial perspective, and lateral in the sense that it's the lateral perspective. So see media here, see media here, and then see lateral here. As simple as that. Medial is close to the midline of the body. Lateral is farther away from the midline of the body. As simple as that. Whenever you are describing something in anatomy, the one that is closer to the medial, to the midpoint of the body is medial. While the one that is closer, that is farther away, is lateral. As simple as that. I'm sure all of us understand it up to this point. And then we have the muscles. Let me quickly go to what we mean by extension and flexion. So look at extension movements. We have extension. Look at this here. If this was a virtual class now where we were in a controlled environment, I would have told all of us to illustrate this thing. So extension is you're moving the leg bone away from the midpoint, while flexion is you're moving it towards, the midpoint. And then lateral and medial rotation, when you flex your hip and raise your knee like this, lateral rotation means you are rotating out of the midpoint of the body, and medial rotation means you're rotating towards the midpoint of the body. Is there anybody that did not understand what I just explained now in this movement? If you did not understand, can you indicate? I just wish we are understanding this. Once you understand this thing, you don't have issues with it. Can we understand? You can just indicate in the comment section so I will know that we are following you. Are we together? Can I proceed?
Please, sir, I have
Hello?
a question.
Okay, so go ahead with
My
your
ne-
question.
sorry, my network was not stable earlier. I didn't get what you said about patella. You said that it covers the femur. Like, I don't really get what you said there.
Look at I was just trying to explain what was already in the notes. Look at what it says here. Are you here now? Can you see what's on the screen?
Yes, I can see it.
Now, see this patellofemoral connection. The anterior aspect of the distal femur. The distal femur means the down part of the femur, right? Articulates with the patella. So let me show you this distal part that is articulating with the femur. Look at the distal part. See the distal part, right? This is the distal part of the femur. Distal, articulating with ulnar patella here. As simple as that. So this patella is covering this distal aspect. If you touch your patella now, you will see that the patella is covering this distal aspect. And that covering is protecting the distal aspect of the femur from direct contact from external, external circumstances. Say you want to kneel down now. I use the example of trying to kneel down. If you kneel down without your patella, it means that your femur, the distal part of your femur, is directly in contact with the ground. Do you understand? And there is a risk of harming all these vessels that run through. Don't worry, when we are looking at the vessels, you see all the vessels that run through this place and why this patella is very important. In fact, there is a buzzer in front of the patella too to show you how important this space is, this patella is. That's what I said. I was just trying to explain what is connecting to what.
Okay,
Is
sir.
that okay?
Yeah, I understand now. Thank you.
All
I have a
right.
question.
Okay, go ahead.
About the distal part of the femur.
Shey there is only 2 epicondyles and 2 condyles there. My question is there something like supracondylar ridge at the
Supra
distal
what?
condylar ridge?
That's for the tibia now, that's not for the femur.
Okay. Thank you.
Yes, it's for the tibia. When you hear epicondyle, it's femur. Condyle, tibia, So
Yeah.
look at, let me use this diagram. So for this, can you see these 2 places I'm marking now? Can you see them?
Yes.
This place now is the lateral epicondyle of the femur, and this is the fibula, the lateral aspect. This is the medial epicondyle of the femur, and this is the medial condyle of the tibia. So
Yeah.
epicondyle is for that femur. As far as you're talking about the knee joint, it is the epicondyles of the femur that are the articulating surfaces for the ligaments, joining with the condyles of the
fibula.
tibia and that of the foot. You understand?
Thank you. Yes.
Yeah. Thank you. Okay, so let's move further. I think with all these explanations, the only thing that is remaining now is meniscus or menisci. And then it's basically the same thing with hip, just different structures. So for extension, let me use this other. For extension, the extension of the knee joint is mainly by the quadriceps femoris, while the flexion is by the hamstrings. Quadriceps can be found in front. Note, please, everybody note. Quadriceps are in the anterior aspects of the thigh. Quadriceps are in the anterior aspect, while the hamstrings and these other ones are in the posterior aspect. Okay, so let's take note of that. And then also remember that the hamstring muscles are the semimembranosus, semitendinosus, and biceps femoris. These 3 form the hamstrings. Those of you that watch football, sometimes, what's that boy's name again in Manchester United that is always having injury? What's that boy's name? I've forgotten his name. One fair boy, one fair man. He's always tearing his hamstring
Mason
muscles.
Mount.
Every time, torn hamstring. Who is that? Victor, did you say something? Did you say something? Mouse?
Mount.
Always tearing his hamstrings. I don't know what the problem is. So whenever you hear torn hamstrings, they call them hamstrings because they are all closely related, but they are different muscles. It's the biceps femoris, semimembranosus, and semitendinosus. So those are the hamstring muscles, just in case you are asked that kind of question in a test or in an exam. Okay, so let's forge ahead. I will provide this what's it called again? This presentation. If I'm kind enough, if the Lord touches my heart, if He doesn't, He will read up. Okay, so then we look at the meniscus. That's if you're talking about one, or menisci, if you're talking about more than one. So the menisci, they are just fibrocartilaginous rings. Look at them here. Look at how they are seated here. So you can see this one. There is one that is C-shaped, the medial meniscus, the medial meniscus. Are you seeing it? And then you can see the one that is circular shaped, which is the lateral meniscus. And the 2 of them, what they do is that they are deepening this place, they are deepening this surface, these 2 surfaces, so that the distal part of the femur can properly fix itself into these knuckles that are in the tibia. So that's just the simple thing that they are doing. They are deepening, they are providing more depth, more stability, so that the distal part of the femur can just hinge into the meniscus and be more stable. Remember, the more inside, the more hollow a surface is. When you put an object that suits into that hollow, it will become more stable. Let's take, for instance, an electric pole. An electric pole. If you put an electric pole into a cylindrical hole that is not deep, it will fall because there's no depth. There's no enough. The depth is not enough to stabilize it. I don't know if you understand what I'm saying. But the deeper that the surface that it is submerging into, the more stable the electric pole is going to be. That's why you see some electric poles falling. They are not deep enough. They are not held deep enough into the ground. That's why they are falling. I don't know if that's understood. Is that understood? I guess so. I wish this my
Yes,
class can be
sir.
talking.
Yes, sir.
Yes.
Okay, thank you very much. All right. So I will move over to, after menisci, we will see the buzzer. There are different buzzers. You see, this one has up to 5 buzzers set. So the first buzzer that we can see here is the suprapatella. Just by the name, you already know what kind of buzzer is it. Suprapatella means above patella. Abi, prepatella. Wait, let me clean this thing. This thing is confusing. Okay, I've cleaned it. Then this one is suprapatella, above patella. Prepatella simply means it is between the patella and the skin. So it's just in front of the patella. That's it here. Then the next one is infrapatella, is below, right? Below the patella, just directly below the patella. And then we have the semimembranosus bursa. The semimembranosus bursa is not, you cannot see it here. Remember that the semimembranosus is part of the hamstring muscles that are behind. So there's no way you'll be able to see this thing from this diagram that you're looking at now. You can't see what is behind now. Okay, that's why I'm not able to show you that one. And then we now have this one called pes and serine bursa. This one is inside, like the inner side of the knee, just by the corner of the knee here. So all these spaces help to stabilize the knee joints, the whole knee joint. All these buzzers. Okay, I've already explained what a buzzer is and all that. So let's quickly move. With this diagram, you'll just be able to memorize it. One of the things that will help you in anatomy, if you're able to look at the images and internalize them, you will pass anatomy like you don't expect, especially gross anatomy. If once you look at the image and you understand it, yeah, that's all, because you can be able to say, just by the names, you are able to say, just imagine all the things we've been talking about today. All of them have names that are coined out from things we are seeing in the diagram. All of them. There's no one, apart from situations like this, pes and serine. Now that is just on its own, doing what I don't know. The remaining of them usually have names that are associated with the organs. So if you internalize the organs, internalize the structures, did I say organs? Anyway, bone is an organ. If you internalize all these structures, you'll be able to pass your gross anatomy very easily. And I will advise, if you're doing anything gross anatomy, always draw, always draw, always draw. I'm sounding like I want it. Please draw. If you don't know how to draw, learn. Draw something. Because gross anatomy is a relative anatomy. We are saying this is relative to this. This is inferior to this. This is superior to this. Once you draw it and the person sees it with our eyes, I've gotten your mark. So please, let's endeavor to always represent whatever we are doing graphically. And then see another anastomosis. Who is that person that asked about anastomosis? Is it Chidima? Is it Chidima Chisom? Chisom, you asked about anastomosis. Are you seeing another anastomosis every knee joint?
Yes, sir.
So this is what we are calling anastomosis. You can see the way they are interconnected all around. So the popliteal artery and all the branches, both the descending and ascending ones, the inferior ones, and then we also see the genicular artery, the descending and ascending ones. So this the A we are seeing here, this is the anterior view. This A is the anterior view, and this B is the posterior view. See the large popliteal artery. You see how large it is, giving off different branches and the rest of it. And then in front, we can see the genicular giving up all these arteries. And then we can also see the popliteal vein. Then let's look at the innervation. Let me clean all these things that I put here. Let's see the innervation and see the clinicals, and then we are done. I'll take a few questions. We are done. Okay. Sorry for keeping us till this time. I planned that we should finish before now. So the vein, the innervation, I also showed you the anterior and the posterior. So we can see femoral nerve. Let me, as I'm talking about it, you know, I'm marking them so that you can see it. So let me start from the ones that we can see here first. Obturator nerve, we can see common fibula, we can see tibial, we can see here, the genicular, we can see, and then saphenous nerve, we can see. But then someone might be asking, I cannot see the femoral, I can't see the femoral and the obturator nerve. The reason why you cannot see them is because they are coming from this ascending position. Remember, when someone was asking about the iliac veins, we saw that these veins, as they are moving along the bodies, they are changing name. It's still the same line, but once they reach a particular organ, they change their name to that organ that they are around. So the femoral, just along this axis, if you follow this part now upwards, you will see that this is associated with the femoral and the obturator nerve that we saw in the hip, around the hip joint. Okay, so it is still along that line, and it is still innervating the knee joint. Okay, so that being said, let me clean this again so that I will not distract myself, and then we'll move ahead to the clinicals. The first clinical we have here is those collateral ligaments. Sometimes they can tear, and they can tear either medially or laterally. Collateral, remember the collateral ligaments that are side by side. You have the medial and the lateral, so they can tear. One of the ways to treat it is by ice compress. You rest, you apply NSAIDs, and then you apply pain reliefs. And if it is torn, you can, fix the tear using surgery. Then the cruciate, remember the cruciate ligaments, the ones that cross in an X form, where the anterior is in front and the posterior is behind. Also, the cruciate can tear as a result of, number one, hyperextension of the knee, and then the posterior cruciate can tear also. There's this injury called dashboard injury. I'm not this one because we don't have many people that use dashboards here. Have bad roads. Imagine using dashboard in no coffee. You will fall and you might never survive it. Okay, so we don't have all those kind of roads that will enable us to do dashboard. But God will help us in Jesus' name. Amen. So these are some of the treatments that we can use for these tears. And then other ones include bursitis, inflammation, and then runner's knee, osteoarthritis, and the rest of them. Okay, I would like to keep to time at this point. I'd like to get questions. I'd like to get some questions at this point so that we can call it a day. Questions. Any questions? I'm sorry for keeping us, this long. I'm just 3 minutes late anyway, be 4 minutes. Questions, please. Please, what level is this? Let me be sure. It should be 200 level, right? Because it's upper and lower level.
200 level, 200 level, 200 level.
Okay, 200 level. People are welcome to coffee. Okay, so I hope you got the whole thing. I hope the class was interesting anyway, with all these diagrams that I put.
It was interesting, sir.
Yeah. Okay, so
I'm not hearing anything.
Leave for a moment there. Sorry. My network glitched. Okay, questions. So questions. 200 level. Are there questions? Any questions? Mira, have you said something today?
Yes, sir. I said something. Thank you, sir. It was impactful, yes.
Yeah. Chidebere, Esther, Oluchukwu. If there are no questions, I think we can call it a day. I think people are saturated already. Me too, I need to go and drink some water first. Okay, in the absence of any questions, I'd like to thank you all for creating the time, despite the fact that this is not a teaching day, but you created the time for your academics, which is the primary reason why you're in the COFLA. So I'd like to thank everybody for joining the class. Hopefully we'll do more of this if I'm chanced, if I have the opportunity, and we'll see what we can achieve. If you have any questions, please forward them to your class representative. Maybe you are confused on a particular thing, clarification, can give you the resources for you to get abreast of what we're doing. Okay? I would have loved to take what's it called? Attendance. Usually I give Google Sheets and everybody fills it. Who is the class representative? Are you here? Is the class rep here? No class rep? Okay, then I've taken a screenshot of everybody that was here. Well, I can't even know people that are here because people are using Samsung. Some people have Samsung as their name. A serious issue. Anyway, no problem. I think you sort it out with Dr. Izuchukwu. All right, thank you very much, everyone. Enjoy the rest of your day. See you later. Wait, please. There's an announcement. There's another class. For those of you who aren't here, there's an upcoming pre-recorded class. I think it's on YouTube. Okay. So let me share my number with the class. Is the class rep here? Can someone represent the class rep, please? Or is this a mixed class?
It's a mixed class, sir.
It's a mixed class, sir.
Okay, so it's a mixed class. Okay,
Yeah.
so please be patient a little. I want to share a link to you for your next class so that everybody, I'm sure all the departments are represented here. All the departments that are here represented, I want to share a link for your YouTube class. I'm sure people will sort it out though, because I don't know what else to do this moment. Okay. Okay, so I'm going to share the link in the comment section to the YouTube class. And then all of you can go to the link and I've shared it. Please use the link.
Hallelujah.
Yeah. So I don't know. We're not able to copy the link. Is this?
So we can't copy the link. Oh.
I think he left already. He left the call already.
Wow. Maybe his network is lagging.
I have the link. I have the link.
JB, share it to department, please.